thanks to all of you. And of course, we wouldn't be having an event tonight if it wasn't for our guest speakers, of which we have many. So if I don't kick us off right away, we're going to have a hard time getting through tonight's activities. Without further ado, I'd like to introduce our first speaker, and that is, as I mentioned, Dr. Arthur Kaplan is a nationally recognized medical ethicist. Dr. Kaplan is the Drs. William F. and Virginia Connolly Mitty Professor and founding head of the Division of Medical Ethics at NYU School of Medicine in New York City. Dr. Kaplan, please take it away.
Thank you so much. And it's a pleasure to be here. I see in the participants list, there's one or two old pals of mine. I shouldn't say old pals, pals who I've known for a long time. I'm the old person in this crowd. As many of you know, I was in Philly for many, many years, been up in New York now for about 9 years at NYU, and have been working on vaccines for about a dozen years, starting at Penn and then continuing here with a working project that we have in place. So the question I've been asked to address is mandates and vaccine mandates. And that should take no longer than 7 or 8 hours to work through all the issues there. A pretty complicated question, but we'll get as far as we can get and then see what comes up in the Q&A. And then I'm sure other speakers will have things to say later on this subject. So the way I want to approach it is tell you what already exists in the way of vaccine mandates in the United States, what exists with respect to healthcare workers now, and then say a little bit about COVID vaccine mandates, pros, cons, and problems that they may face coming up. So
the sanctions committee would not discuss that. I mean, sanctions would just look at sanctions. So, and whether the sanctions are reach a threshold that allow us to
Barry, could you go on
from the
so let me
from his credentials.
Make sure everybody is muted out there.
For that to happen,
excuse me, whoever's talking on the phone, can you please mute your microphone?
Thank you. We'll have some time for questions for sure, so you can unmute later. First, there are many mandated vaccines in the United States. Children's vaccines for measles, mumps, rubella, newborn vaccines have been in place for decades. They are interesting because they are mandated vaccines. The alternative, if you don't want to vaccinate your child, follows in 2 ways. One is homeschooling, which you can choose to do. There is only one state, I'll give a prize if you can guess which one it is, that actually suggests vaccination for homeschoolers. It's North Carolina. Who would have known? Otherwise, it's up to you if you homeschool what you want to do. That's interesting because obviously, if you choose not to vaccinate, your kids can still go to Walmart or show up at Chuck E. Cheese or wander around bus depots, and there still is some risk to the public. Most states that have mandated vaccination permit exemptions. And so a parent may exempt their child if, one, they have a health reason. Every state allows you to say, for example, my child has an immune disease. There's no point in vaccinating them because they can't build up any antibodies, no resistance to anything because their immune system is harmed. They are immune deficient. Similarly, a child undergoing cancer treatment and a child undergoing transplant. Every state permits health exemptions. There are only 2 states that permit nothing more. Again, this is strange. You'll never guess which 2 states they are that don't let you opt out, except for health. I don't think you'll guess. West Virginia and Mississippi. And that's because they both had strong public health department efforts long ago to push through vaccination before everybody got woke and decided that they wanted to talk about their liberty or their interest in the right to refuse interventions. So they just slid them along, and they are the 2 states that have them. Other states permit exemptions for religious reasons, or for what's called philosophical reasons. I'm a PhD in philosophy. I love the fact that in public policy, legislators have permitted philosophy to be an exemption reason. It's the only area I know where you can sort of say, I believe in utilitarianism, so I'm not vaccinating my kid or whatever. I'm not quite sure what a philosophy exemption actually would be, but there it is. And what it really means is personal preference. You don't want to do it. So as we understand those childhood vaccination requirements, there are strong mandates. You don't get out of doing this unless you have a health reason, and that always is certified by a doctor. There are weaker mandates. You can opt out on religious grounds in some states. You can opt out on personal choice grounds in some states. It's about 20 states that give both religious and personal. Some give personal. So keep in mind, when we think about mandates, the first lesson from this history is there are strong mandates and weaker mandates. A mandate can also be implemented, I'm going to put it this way, with hurdles. Yes, you can have a religious exemption, but if you're going to claim it, you need to have your religious leader write a letter saying that it is against your religion to be vaccinated. By the way, I and my students have studied religious views on vaccination. Every major religion is pro-vaccination. They want you to protect the community. There's no major religion that isn't. And even Jehovah's Witnesses, who historically have opposition to blood transfusion, don't mind vaccination. And Christian Scientists, who again often have a lukewarm attitude about medical intervention, leave it to conscience to decide about preventive vaccination. That is, Christian Scientists also will let you go to the dentist, and there are some procedures they will allow you to do, like fixing a bone break. So across the board, the organized, recognized religions are not in the camp that says we don't like vaccination. The other thing to keep in mind about strong and weak mandates is that you can also say, if you want to opt out on grounds of health, you have to get a doctor's certification. You have to prove it, and you had better bring those records in, or you could just take the parent's word. And those are obviously different levels of trying to enforce a mandate, and you see that in different states. I will tell you, and I'm happy to talk about it in the question and answer, I have been involved in removing the religious exemption in state laws. It has now been removed in California, New York, Maine, and as of today, where I'm talking to you from Ridgefield, Connecticut. We just went through this debate here. The argument was, yes, you should be free to practice your religious beliefs. And no, we're not going to try and define what a religion is. But the public health concern about infecting other children with measles or mumps or whatever it might be is too strong relative to religious freedom. Courts have backed that up. There are a number of court decisions that have said you may limit religious freedom in the interests of public health. And those legislatures have decided that that argument is ethically persuasive and taken out the religious exemption. That doesn't mean that you still couldn't homeschool or try to school remotely, which has become an option, post-COVID. We didn't really think about that, but you can't really send your kid to school unless they're vaccinated, unless you have a health reason in those 4 other states. So they're getting more like Mississippi and West Virginia were, just accepting the health exemption. So that's one area. The second area that you're all going to be familiar with of mandates, although we forget about it, is to go to college. And in America, many colleges have said you cannot come here unless you get a meningitis shot. It's a private entity declaring their policy at Penn or Temple or wherever it is. And they basically say on health grounds, this is a highly communicable disease. We've had outbreaks. We don't want them anymore. You can't come to our dorm unless you show us proof of meningitis vaccination. Again, this is a strong and a weak thing. There are schools that say, I want to see it at the health service, certified by your doctor. There are other schools that say, hey, when you're moving in, did you get a meningitis shot? Yeah, I did. And that's as far as it goes. They don't really police it. So you might say, again, we've seen strong mandates about presuming you're going to do it and proving it, and weak ones that have said, we'll take your word for it, but don't check. So again, when we hear about mandates, remember, there can be opt-outs or none or few, and then there can be ways to prove that you did what the mandate said. As far as I know, there are no police, no authorities that come to your house and say, you said you took this vaccine and you didn't do it. We're going to vaccinate you here and now because it's a requirement. We don't have the vaccine police, but you will be amused to know that we once did. In smallpox outbreaks in 1905, City of Boston and City of Philadelphia both did send the police to accompany vaccinators. We did once have vaccination police who would grab you and vaccinate you against smallpox, whatever the hell you thought. That led to a Supreme Court case about the power of the government, in this case Massachusetts, to mandate vaccination. And the Supreme Court upheld it in a famous case called Jacobson, which you don't need to hear about. But that has been foundational for subsequent cases and challenges about state authority to mandate vaccines, all of which have been held up by the courts, all of them. So when people have challenged, say, losing the religious exemption in California and gone to court, they have lost. New York has had a challenge, it has lost. So courts do acknowledge that in the name of public health and protection of the community, and I might add, protection of the weak and vulnerable, remember those people who can't be vaccinated, either children or adults, that in order to protect them, we have to vaccinate everybody else so there's less contagion. So there is a legal as well as an ethical basis, if you will, for mandates that way. Let me move next to a discussion of existing healthcare worker mandates. And this has a Pennsylvania angle that you'll all like. Many years ago now, probably 12, I was working at Penn and I got friendly with a man named Paul Offit. Some of you may know Paul, pediatrician and infectious disease expert at CHOP, Children's Hospital of Philadelphia. Not a slouchy place, one of the preeminent places in the world for taking care of very sick kids. And he and I were talking, and he told me that 3 kids had died in the CHOP neonatal nursery from the flu. When a newborn is born, they don't have any immunity except that conferred on them by the mother. There is some passage of immunity through the placenta to the baby, but newborns are pretty vulnerable. And if the mom doesn't have a flu shot, then the child has no immunity against the flu and they are highly susceptible. One thing you might keep in mind coming out of this phone call is if you were going to visit your newborn child or your daughter's newborn child or relative's newborn, I would be asking if they had a flu shot because it really is a risk factor for new babies. And as we'll see in a minute, it's also a risk factor for nursing home residents. I'd be asking the same thing there too. But because we saw those 3 deaths, I said to Paul, well, how did that happen? I thought everybody would get a vaccine and, we take care of that. Well, he said, no, we've been trying to persuade people to take vaccines for years and they don't do it. All we get is 60, 70% of the people who work at CHOP vaccinating, and we never get past that. Even when we bring the vaccines to the floor, even when we give them a free hot dog, even when we try to make it a fun event, there are some folks who, for various reasons, laziness, fear, hesitancy, whatever, don't do it. And I said, I felt that was wrong, that we should try to mandate vaccination to protect these newborns and children and parents from getting the flu. Some of you know the flu vaccine varies in its efficacy. Some years it's only 30 to 40% effective in getting against infection. Some years it's up to 70%, depends on the viral strain, like we're hearing about now with COVID viral strains. But it does do a good job of making the disease less lethal. So people still can get the flu, but they don't get as sick for as long, even if they're not totally protected by the annual flu shot from getting infected at all. So it's still a benefit, and it helps, by the way, to keep the workforce in place so that you don't have a flu epidemic in January at CHOP and 80% of the nurses call out sick. It's important to realize that flu vaccination is good for the workforce, both to protect them, to protect their patients, and to make sure that people can provide care, that they're not sick. So we went through that argument, and I said, let's push to see if we can get a mandate established at CHOP. And Paul and I went around and gave out the facts just as I gave them to you. And people were like, I don't know, not sure I want to do that. I don't think you should make me do that. And I said, what's missing here in trying to push through a mandate is the ethical argument about why it's right to mandate. Let's add the ethics to the facts that I just gave you about flu shots. And what I came up with a 4-part argument. First, every code of ethics in medicine, nursing, PT, pharmacy says patient interests come first. It does not say healthcare worker choice comes first. It says patients come first. Second, every one of these codes, and I didn't write them, nurses, doctors, pharmacists, whoever, social workers did, says do no harm. They'll recognize it, comes all the way back to the Hippocratic Oath. Do no harm to your patient. Third, there is a strong commitment in most of the codes and in all of the ethics literature that you should protect the vulnerable, that they have special demands on your moral duties, newborns, children who can't build an immune response, or nursing home residents who are very prone to being made sick by the flu. Lastly, be a good role model. If you're going to tell people to do healthy things, try to do healthy things yourself. It doesn't mean you can't be an overweight doctor or a doctor who smokes, but you have to try and say, I'm trying to stop these things. I know it's hard. I'm going to work with you to do it. And I too, perhaps, am nervous about vaccination, but I think you should do it and we all should do it. So I'm going to be a good role model. We used those 4 arguments, went back to every department at CHOP, said this is why we think there should be a mandate, and the opposition disappeared. And we put the mandate in probably 12 years ago at CHOP. Then we did the exact same thing at the hospital of the University of Pennsylvania. Got a little more resistance at the end. We had 6 or 7 employees who still said, I'm not doing it, partly because they said vaccines contain pork products. Wasn't true. Some of them were worried about fetal cells being present in the vaccines. That wasn't true either. And we can talk about that later if you're interested. And we fired 6 people, fired them. Subsequent, in the next year, the vaccine mandate was accepted. I moved to NYU. We put the vaccine mandate in here. And you'll be interested to know the vaccine mandate at NYU applies to anybody who's an employee, not just clinical people, secretaries, people who are transporters of patients, people who are in the back office, the legal department, me, you name it. Our dean and CEO decided we're going to do this across the board because you still could spread infection from secondary contacts in. And our vaccination rate today at NYU is 99.7%. The only people who are out are those with health reasons who can't vaccinate. So, very aggressive. It is a mandate. I would call it a very strong mandate. It is set by the employer in this case. The employer may have to negotiate with a union to get their acceptance if they're going to try and impose a mandate like this. Some hospitals around the country have done it. Since I came to New York, we passed a law in New York State requiring flu vaccination for all healthcare workers in hospitals, nursing homes, home care, and hospice. So they're all covered, and you have to get a vaccine, or you could be accommodated by working, again, from home or being put under that law in a back office, if you will. But eventually, the group that accredits hospitals put in vaccine mandates as a requirement for hospitals in all states. Today, there is a very high compliance with flu shot vaccination in most hospitals, most nursing homes. And by the way, the idea spread to Canada and other countries, healthcare workers being seen as in need of protection for themselves so they don't get sick and go off the job in need of protection so they don't harm their patients, and then just a good thing to protect themselves. And the moral arguments being that you have a duty to do this because you've got to take care of your patients and protect them, roughly speaking, before anything else. That's the ethical basis for the healthcare worker mandate. So that history is there. Now we come, last part of my remarks, to COVID. So COVID vaccines are out there, and they are out there in the weirdest way possible that very few people are commenting on, but it's totally weird. It's weird because they're out there on an emergency use authorization. Some of you may have heard that phrase. Historically, there may have been 6 or 7 drugs or vaccines that the FDA said, yeah, early data on these drugs or vaccines looks good. We're going to let you give it to somebody before it's licensed, before we've had a full approval of whatever it was. The number of people who have gotten emergency use authorization access historically has probably been less than 2,000. There was a vaccine approved for anthrax for like 100 Defense Department workers who were deemed at high risk of exposure a few years ago. We had a meningitis B vaccine approved at a couple of colleges where they had outbreaks, where we only had meningitis A vaccine, and B was not approved yet in this country, but it was approved in Europe, and they let it be used there. Today, there are hundreds of millions of people getting vaccinated on an emergency use authorization. If you said to me, what's the legal situation? The answer is, who knows? It would be weird to say, well, you can't mandate a vaccine under an emergency use authorization if you give it out to tens of millions, hundreds of millions of Americans. You'd look crazy. Why would we distribute it that way and then say, on the other hand, it's too risky or too whatever not to mandate it for healthcare workers? If you also looked at what lawyers like to do, or people who are more anti-vaccine or hesitant, they still may say, you know what, I don't care. I'm going to challenge a decision to try and mandate for healthcare workers or anybody else, given only emergency use authorization. When you get to licensure, come talk to me. Licensure requires longer data collection, normally a year and a half. We got these emergency use things on 4 months. So, okay, we're getting down the road. Licensure should be imminent or soon. But once you put those emergency use vaccines out there, guess what? It's hard to finish the studies because everybody goes and gets them. So those studies are falling apart because the placebo group says, I have a right to know if I'm in the placebo group because I want to go get Pfizer, Moderna, under emergency use authorization. I don't want to stay in the placebo group. So whether we get data that would permit us to license under the speed or the time FDA is used to, I have no idea. So it's a very complicated situation because of this strange, murky, untested, unknown waters that we're sailing in with massive EUA distribution in the US and with Janssen and AstraZeneca also under EUA approval, and more vaccines are coming, Novavax, seeking EUA approval. We just never did this. You could say we never had a plague like this. We never had 500,000 plus dead people in America. That's why we decided to move quickly, more quickly than we might have with vaccines. That's part of the warp speed idea, but uncharted waters. So the last comments. Some places are already mandating vaccines that have nothing to do with healthcare. 50 colleges have said, if you're going to come live in our dorm, you're going to be vaccinated. Rutgers, NYU, Cornell, Brown, Notre Dame, can't remember the rest, a lot. That's a private entity mandating. I think they have the right to do it in the name of health, to say we have to protect the students and we have to protect our janitors and our workforce, that just as we did with the meningitis vaccine. The fact that they're doing it for EUA vaccines, I don't think is going to be challengeable in the same way because it's their decision. to say what they require for safety, and you'd have to challenge it and say, well, it's not safe, or it doesn't contribute to health. And that would be a strange thing to say, as I keep insisting, having vaccinated 100 million Americans, you'd be in a weird, it'd look awfully strange to say, well, no, it's not safe. And no, it doesn't work. Even if you came up with blood clots as a micro rare event, I think you'd lose. Secondly, some sporting events are requiring vaccination for entry. Buffalo Bills have said when they open up, you're going to be vaccinated to come in. How they're going to prove it, what they're going to require, whether they're going to make you show them a card or an app from a private entity, I don't know, but there are entities doing that. Qantas Airlines has said you're not going to fly unless you can show us you're vaccinated. And I happen to know a number of private employers are starting to say, soon we're going to demand vaccination for return to work in person. They have sales forces that they want to have people trust that they can go out and visit. And there are places like Broadway, very close quarters, poor ventilation, you sit on top of one another, older crowd, nobody's going back there, or a cruise ship, I suspect, unless the business says we're vaccinated. They're going to have to vaccinate their employees, and they're probably going to have to insist that the audience is vaccinated. Maybe an alternative could be a quick COVID test to prove you're negative before you go in, but that's a pretty big burden to try and do at the Buffalo Bills football stadium. I'm not saying they can't, it's just, I don't know, we'll see. If you said I work somewhere and I don't want the COVID vaccine because I'm still nervous about it, there is an obligation to accommodate you if possible. Some jobs would let you work from home and you have to try and do that. But if you can't do that, somebody says I can't be on a cruise boat working remotely, the employer then has the right to say, for health reasons, we're an at-will, as they say, employer, and we're not going to keep you on, or we're not going to hire you. You can't discriminate, but you are able to make decisions about what's safe and healthier in the workplace. And there's a long history, as we all know, of trying to make the workplace healthier. Sometimes challenged, but always upheld if it's reasonable to tell people to wear helmets at a work site, or whatever it is, that trying to clean up the air and so forth. Somebody says you have to wear a ventilator to work in here. You may not want to, but you have to if you're going to work in the place where there's a lot of pollutants in the atmosphere. So I'll conclude by saying this. I think you're going to see some health systems try to mandate vaccines for healthcare workers, even under the EUA. We may do it here soon at NYU Health System. I think the feeling is it's too dangerous not to vaccinate frontline healthcare workers, particularly for older patients who are high risk, particularly in nursing home settings where we had terrible, horrible death rates and almost a Holocaust. 20% of the people who died in Massachusetts and New York, nursing home residents. My mother died in a Massachusetts nursing home last year from COVID at 94. A lot of group homes where people with intellectual disabilities live, highly likely to die from COVID, 6-7 times the rate of ordinary individuals. And I could go on, but it's a high risk world out there for many patients. So I think you're going to see some systems try it. Other places may say, we're not going to try it until we get the licensure. You may not see that, but eventually we will see it. It will piggyback on the flu vaccine mandate that's already been established. It's going to happen maybe a year, maybe 18 months, may only apply to boosters because we may have those by then, but it's coming. I think you can be pretty sure you're going to see it. So I'm going to end. I think I've got a little time left for some Q&A, and I'm happy to let you jump in. Victor, you want to run the letting people speak, or you want me to do it, or put it in the chat box, however you want to do it?
Thanks, Dr. Kaplan. So, one of the reasons we do use Zoom meeting is because it does allow people to turn off and on their own mics. I am perfectly okay right now trying this. If you'd like to ask Dr. Kaplan a question, please unmute yourself, ask the question, and then mute yourself back. And just generally, I should have said this in the beginning, while we have presenters speaking, I would ask that you just keep your microphone on mute so we don't get background noise. So Dr. Kaplan, thank you so much. I think, not only is the COVID-19 vaccination campaign an issue for serving our older adults, but you tied it to another one, our influenza campaigns that we run annually, and we'd like to open it up for any questions our participants have at this time.
Art, I'll ask you a question. With the politicization of this whole vaccine debate that seems to have overcome the code of ethics and ethical conduct, how do you combat that part of this argument?
Well, it's obvious. I just, for the first time, went on vacation. I went to Eastern North Carolina to the beach near Wilmington. I drove through Eastern North Carolina. I don't think the election has been accepted yet. So politicization is there. We're watching some reaction to the George Floyd conviction of Chauvin, and not everybody is applauding. Not everybody sees it as a step forward. I see it. So we are polarized. There's no doubt about that. At the same time, within the healthcare world, the institutions, I think, are more amenable to trying to protect patients and trying to keep the workforce in place, even in red states or even in highly politicized communities. I think the healthcare workforce mandate has a much better chance to go forward. Now, look, it still requires education and trying to persuade people. You don't just announce a mandate and say, everybody's getting flu shots tomorrow morning. You do need to have people come on board. You want support. You want them to understand. You want religious figures to speak up in favor. You want celebrities or local celebrities to say, please protect my dad. Please protect my baby. Those are important. But I think healthcare is a little different. I think we can get it there and get it through. If I tried to announce tomorrow that everybody in Eastern North Carolina is going to get a COVID shot, I'm not sure I'm getting that far, he said understatedly. So the healthcare world is different. And remember those obligations I trotted out on my moral argument about the flu shot? They work. People understand them. The healthcare workers get it. It's harder to claim those obligations for the general public. I mean, I could say protect your neighbor, help the community, look out for vulnerable people who are in your town, sick child down the street, watch out for grandma down the street. But a lot of Americans are so consumed with choice, autonomy, liberty, that they don't make the duty to the neighbor a top priority. Now, we can try to persuade them that they should, and I'm up for that. I am willing to engage that argument and take on allies. For example, in the New York area, the Archdiocese of New York came out very strongly pro-vaccination. Even though there was this issue about fetal cells, they said, look, that was a long time ago and they haven't been used in an active way, and whatever moral hesitancy we have about that, protecting the community overcomes it. And we stand for vaccination. So that's an example, where you can sometimes enlist the right forces to go out there. I've had a little success also up here in Connecticut with some of the African American community in terms of urging vaccination to overcome hesitancy with churches, church leaders speaking up. That's been a very effective forum. So, but would I say, we're going to overcome all community hesitancy soon? No. But I think we're likely to see it on the healthcare workforce side. And then again, once that happens, look, I was starting to suggest you go to visit your grandmom or mom in a nursing home, it's fair game to say, I only want vaccinated people to take care of her. I don't know that I'd ask her, are you vaccinated? But I would say, I request people who are fully vaccinated, including COVID, to care for my grandma. Is that something you could do? You're putting the pressure on visitors. We have a policy that we want you to be vaccinated. You start to turn the dial up. Does that make sense?
Yep.
I have a question about the people with genuine medical contraindications. There aren't many of them, but do we make an accommodation for them, or do we say, sorry, you have to watch the Buffalo Bills from home, or you can't go on this cruise, or you can't work in this nursing home?
Yeah, this is Rob giving me some legal flack. How are you? I would answer it this way. You are bound to make reasonable accommodation. If you could sit in a special section 6 feet apart in the Bills Stadium, I think you should probably give it a go. Try to say we don't have a risk here. And mask. If you're willing to do those things, okay, we'll give it a shot. Other things like the cruise ship, I don't think so. I don't think you're cruising, even if you have a health reason, be hard to isolate you and mask you and do what you need to do in those tight quarters. It's like asking the submarine crew, can we put an unvaccinated person in this tiny space? Or astronauts, they won't let you be an astronaut unless you're fully vaccinated. They won't let you work on an oil derrick out at sea unless you're fully vaccinated. They don't even it's hard to get you in and out if you got the flu or something there. So I do think my argument would be, both legally and morally, you accommodate as best you can, but there are situations where you're not going to get hired, and there are situations where you're not going to get to go.
Great. Dr. Kaplan, we're at the end of our first 45 minutes here. So I do want to say thank you so much. I think you've brought up some very poignant obligations and duties as you've framed them for us, both as healthcare providers, but also as individual caregivers and professionals in the healthcare profession. And I think that's such a powerful way to frame, our duties and obligations in this case. As you put it, the duty to do no harm is an important one for us. And, certainly in the COVID-19 vaccination campaign environment, there are extenuating circumstances because it's under EUA. But, I think you've definitely given us a framework to approach some of these ethical questions and maybe not just rush into the mandated vaccination policy in this particular circumstance. Even though we've seen it work very well in protecting people in other vaccination campaigns that are more well established.
Yeah, it'll be interesting. The way in maybe for Pennsylvania, try it in a system or two, see what resistance comes up, see if people want to sue or worried about the emergency use authorization. I'll end by saying there are cultural, ethnic, many reasons why people have some distrust of vaccination, and those have to be addressed. But I suspect they're less in the healthcare worker side of the street than they might be in the general public side of the street. And it may be that a big health system, like I said, NYU may try it and sort of see what's the resistance, what's going to happen before licensure. I don't know if we want to wait that long. So it'll be watch for it. At the end of the day, we'll see.
Outstanding. Thank you so much. We invite you to listen to some of our other speakers as you can. It was really our hope and intent tonight that we create a panel that looks at this issue from various perspectives. And I think, as I mentioned, due to the work of the education task force for this event, we've got a wonderful group of perspectives here. It is truly my pleasure to introduce our next speaker, the Reverend Dr. Derek DeWitt Sr., who is Chief Financial Officer of the Maryland Baptist Aged Home of the United Baptist Missionary Convention. Derek, I hope I got that right. And Senior Pastor of the First Mount Calvary Baptist Church in Baltimore. The Reverend Dr. DeWitt was recently featured in an interview on CBS Sunday Morning, and he will talk about vaccine hesitancy and I believe some of the important role that it plays in helping to keep the COVID-19 out of our buildings in many ways. Dr. DeWitt, I turn it over to you.
Well, thank you. And thank you, Dr. Kaplan. I do want to say I almost jumped in when he said, am I muted? No, I'm good. Okay, can you hear me okay? Yeah, I almost jumped in when he said the overweight doctor, but then a better segue is when he talked about perhaps there's less hesitancy when it comes to healthcare workers. And that's an interesting thought, because I got a call last week from the governor's office of Maryland saying, will you be an ambassador for COVID vaccination as it relates to trying to get healthcare workers or long-term care, assisted living, and senior living facilities workers vaccinated, because we're only at about 50% of all of those categories as it relates to the workers in the healthcare environment, which was really shocking to me. Even more importantly, when I did my first, we were very fortunate to get the vaccination very early. We did our first vaccination clinic on the 23rd of December, 2 days before Christmas. And then I get a call Christmas Eve saying only 11 employees out of 42 in this one facility took the vaccination. And that really shocked me, because we're in a marginalized community where the Maryland Baptist Age Home is a 100-year facility that was founded as the Maryland Baptist Age Home for colored people 101 years ago. And then we are in this very unique setting and vulnerable setting as it relates to the COVID, because even out of all of the people that died in nursing homes, there was a disproportionate number of them that were Black and brown people. So it was hard for me to wrap my head around why our employees would not take the vaccine. But fast forward, we're just now in May, approaching the month of May, the end of April, and we still have a few employees that refuse to take the vaccine. So that, and Dr. Kaplan talked about the various reasons. I'm sure someone will talk about that later. But my job was to talk about we're being in this vulnerable state, but still we have been able to keep the disease at bay. And I want to preface these comments by saying nursing homes could have done everything right and still have fallen victim to this pandemic. I think we're fortunate that we haven't had any COVID cases amongst our employees or our residents, but I don't want my comments to be seen as bragging. It's very important that we understand that, this is a pandemic and it could have affected anyone. But one of the things that I realized early on, when I heard our commander-in-chief say we only had 15 cases, and by the end of the week, it would probably be zero, it really struck me that this was the attitude of the leadership. And it reminded me when I was in Desert Storm, and I'm pulling a radio guard at night, and I heard the first President Bush said there was no American troops in Iraq, and I was sitting in Iraq when he said it, and so that kind of resonated with me. And I said, it sounds like this pandemic is going to be another one of the situations of where we're on our own. So we acted immediately. We acted early. 28th of February, we locked down our facility. No one who did not have to have direct contact with our residents were allowed into the facility. Our residents were not allowed out of the facility. There was no visitation. So we were fortunate that we had spent a lot of money in the previous years on an infection control quality assurance nurse, and people thought I was crazy spending over $80,000 a year on a quality assurance infection control nurse in a 30-bed facility, right? But when I got there, I was a finance guy, knew nothing about long-term care or medical, and I said, well, I got to study this thing. And in nursing homes, what kills people? And they said infection. So it made sense to me that we had to put a lot of eggs in the infection basket, right? So that became a priority for us. And little did I know when I did that, I took a lot of heat from the board. As it relates to that, I had to take a pay cut in order to pay for it, right? But as it relates to that, who knew a pandemic was coming? And in a way, it was vindication for me, because I said, wow, yeah, look, we got this infection control manual now. We know what to do. So we acted early. We immediately locked down. We acted, I call this the 4 E's. We were very excessive. And as I'm writing this book on pandemic response, we was very excessive. So we started immediately stockpiling PPE, getting masks and getting gowns and disinfectant and all of the stuff that we thought we might need. And then we were extreme in our measures. Our questionnaire that we ask our employees go further than what the normal questionnaire would be. Have you been in contact with anybody? Have you been on a trip? So, you know, we went almost to the level of what did you do when you left work last night and who did you do it with, right? So we were very extreme, but like Dr. Kaplan was saying, all of these measures took buy-in, right? We began to hire additional staff so that we can clean around the clock, right? Very excessive cleaning around the clock. And then the fourth, so we were early, we were extreme or excessive in the stockpiling of our equipment, hiring of personnel. And then, you know, we were just extremely, extremely cautious. Anything that the code said we had to do, we looked to go a little bit above and beyond whatever the mandates were in order to keep our employees safe, because we didn't, you know, we're a small facility, mom and pop shop. We knew that if this virus got in, it was going to probably be the end of our 100-year legacy of providing long-term care to some of the most vulnerable population, right? And we did not want that to happen. So, yeah, so I took a lot of residents, families were not happy with us in our extreme measures, but it is proven to be safe. It's still proven to be safe. The fourth E, early, excessive, extreme, but emotional. We had to have an emotional response to COVID because we understood now that our residents are going to be locked away, right? Pretty much in their rooms, no communal activities. So we wanted to make sure that we enhanced that experience for them. So we made sure that every residence had television, radio. We talked to them about what mattered to them, what individual things we can supply for you. We hired additional activities personnel to be able to fulfill those requirements that our residents have. We enhanced the culinary experience for them to make sure that these meals that they're now taking in their room was specially prepared or decorative, or the presentation was enhanced by simply putting a live flower on the tray, for example. This, you know, then we had to also make sure that we kept in mind the emotional toll that this was taking on our workers. So we did things with them to help this COVID navigation easier for them. We didn't want them to take public transportation, so we supplement their transportation costs so that they wouldn't be on the bus or the train bringing COVID into the facility. We provided food boxes and things like that for our employees who had to work long, excessive hours and weren't able to do shopping for themselves. We encourage Instacart and Amazon and those types of things to keep our employees from having to actually physically go to supermarket, placing themselves in vulnerable positions, and then bringing that back to the nursing home. And this was at a tremendous cost at a mom and pop shop. And I will say that the PPP loans and the stimulus package really helped us to stay afloat and allowed us to concentrate more on keeping our employees safe. I know I'm running out of time, but the thing I would say is even now with vaccinations coming, we made vaccinations mandatory effective 31 May. If our employees are not vaccinated, then they'll be taken off of the schedule until they can show proof of vaccination, right? So we haven't gone to the point where we're going to fire you, but you're not going to be working if you don't have vaccination. Dr. Kaplan hit all of the points, because while it's the right of the individual right now not to take the vaccination, we have to weigh the safety of the resident over the right of the employee. And in my estimation, in my calling, the resident wins that battle every single time, right? So that's kind of where we are on the mandate. I think that it's impossible for us to keep our residents safe if we have a mandate. If we don't have a mandate in a facility as small as ours, it could mean the end for us with one infection. But imagine these larger facilities that don't have a mandate. It's hard enough to control infection um, as it is, but not having a mandate, to me, it just leaves you open for um, more of what we have experienced over the past year. I got a letter from a lady who saw an article that was done on us in the AARP magazine, and she was really just, congratulating us on keeping COVID out. And she said she couldn't believe 11 months into the pandemic that her mom passed away due to COVID after going to a rehab facility after knee surgery, right? So, and then I think because we have to continue to be excessive and extreme in our approach and go above and beyond what anybody else tells us that we would have to do. And lastly, I just want to say it is going to take some partnering with communities of faith to help push the narrative of the vaccine, how important the vaccination is. People, for the most part, trust their pastors, their priests, their imams, and their rabbis. And if we can bring them in as partners for COVID vaccination policy, I think it will go a long way in helping us to get beyond this pandemic and getting everybody vaccinated.
Perfect. Reverend Dr. DeWitt, thank you so much. I think you've painted a really powerful picture of that obligation we have to protect the people we serve, our residents. And, that's such a major force in this discussion, how those individual rights balance against those duty of care obligations that we establish with each person we bring under our care. And certainly in a very heartfelt and impassioned and wise way, you've helped us to paint that picture a little bit. So thank you. We will, again, as I said, have a question and answer session here at the back end. So I'll invite the Reverend Dr. DeWitt to stay with us. Certainly, if you have any questions for him, jot them down. But it is my pleasure to introduce our next speaker as well. I'd like to introduce Dr. Annette Gadabeku, who's an associate professor and assistant dean in the Community Health Drexel University College of Medicine, and she will be discussing her perspective as a physician, addressing diversity, equity, inclusion, and frontline workers of the Black and Brown communities. This is such an important issue as we're starting to hear and frame out here to understand where hesitancy comes from, where a temptation to decline might come from, and I think Annette will help bring some life and breath to that discussion. Annette, please take it away.
Good evening, everyone. Thank you for having me a part of this really important discussion. And as I sit here listening to Dr. Kaplan and Reverend Dr. DeWitt, just formulating a lot of my thoughts around this issue of vaccination hesitancy, mandating vaccinations, particularly in our Black and Brown communities, many of which are staff and employees at many of the facilities that we are discussing today. And I'm not here to, convince or talk about whether vaccines should be mandated or not, but I definitely would like to speak to approaches as you all are deciding and discussing and going forward with your decisions on what to do at your respective organizations and facilities. I am a family physician. I have been working during the pandemic in both the inpatient and outpatient setting. I have seen firsthand the various effects of COVID-19 and what has occurred throughout those populations, particularly in the Black and Brown communities. I've seen people do well, and I've seen people do not very well. And I've also experienced and seen how people have responded to the opportunity to become vaccinated. And one point that did pop out to me in Dr. Kaplan's talk was, him saying about healthcare workers and healthcare workers, probably because of their experience or what we assume to be their knowledge of health, would not have as much of an issue getting vaccinated. I would say not to underestimate people's hesitancy, people's experience, people's thoughts about vaccinations, especially with COVID-19 during this time. I do think that education has been a key in whether or not people go ahead and get vaccinated. And again, not underestimating where people are, especially in healthcare workers in Black and Brown communities. At the beginning of the availability of vaccine, and halfway through, we say the vaccine was available in probably around December for healthcare workers. I was even very surprised at the lack of people getting vaccinated, particularly in those communities, but not all the way surprised as I heard the numbers. So in the beginning, it was about 30%. When we looked at those healthcare workers in facilities very similar to those we were discussing, the vaccination rate amongst Black and Hispanic, particularly African American communities, was quite low compared to white Caucasian counterparts, where we were seeing vaccination rates very early in the 60s to 80%, even amongst Hispanic healthcare workers was a little bit higher, where we were seeing numbers around 30%. I think there are definitely reasons behind that. We can talk about, and I know many people know about the history of African Americans in healthcare and the disparities and the mistrust, experimentation, and especially with something where it's emergency use approved, and the thoughts that this was very quickly brought out and made available. There are several reasons why people may be hesitant in these communities. But it doesn't mean that it had to stay there. As we moved through, from December and then the late, getting into January, February, March, started to see that needle move a little bit further. And now we're somewhere, as Reverend Dr. DeWitt mentioned, so we're around 50%, maybe getting a little bit higher. And I do think there are several reasons for this. One is more information and education about the vaccine, about the effects, and then the other is about seeing others doing well, not having, a third eye or an extra limb grow. Might be facetious, but, really not having major effects. Of course, people are still concerned about long-term effects, but as they are seeing their loved ones and those people they know and love getting vaccinated and seeing that they're doing okay, feeling more and more comfortable to go get go get those vaccines. My own personal experience, I'm a physician, and I see a question in the chat about education, and I do think that was a huge, and education goes a long way. You talk about fear and anxiety, philosophical issues, and all of those things can be addressed by education. Not to say that that's all a part of it, but education goes a long way. And education was significantly lacking in the beginning as the vaccine became available, even among healthcare workers, even among us as physicians. I will say, even for myself, just being transparent, when the vaccine came out, I didn't have a lot of that information that I have now available and transparent. And, there was a little bit of hesitancy even for me as a healthcare professional. I did get my vaccine on December 18th. It was the very first day that my hospital had vaccine available for their employees, and I got placed on the list at 1:00 p.m. on that day. And I remember having that opportunity and going back and forth in my head, but yes, it was my responsibility to my patients and mainly to my family, having two parents who are older and have high risk medical conditions, that I decided to go ahead and get the vaccine. But that's not to say that we can't underestimate the fear, the anxiety, the misinformation that people have around just basic healthcare issues, disparities, and particularly COVID-19 and the vaccine. Also, a part of my experience I'd like to share is just approach in uh, helping and assisting my fellow healthcare workers and staff. Many of my staff was extremely resistant to getting the vaccine. And I decided to just one day have a little huddle with my staff at the beginning of one of our patient sessions and just talk to them, ask them about, their questions, what their concerns were, what their fears were, what they are hearing. And one by one, just, start to educate and give that information. Not to say and not to twist arms that they had to get vaccinated, but at least to give accurate information and have them eventually make the decision for themselves. Many of which they said at the end, I didn't realize this, or I didn't realize that, or I thought this and now I understand. And maybe I'll consider. And over time, that consideration became actually action. So I think there are a few things to just take home as we are moving towards, if you are mandating vaccine and you have people that are hesitant about getting the vaccine, is first of all, don't underestimate what their level of fear and anxiety, knowledge about what it is and what the effects are, and anything related to it. I think education is huge in this situation, and meeting people where they are, talking about the transparencies and acknowledging experience, acknowledging where they're coming from, and trying to really find out. Everybody's different. Not everybody is not getting vaccinated for X reason. There are some very interesting reasons out there. I think in a pre-call, somebody talked about how somebody thought that they were using different needles for African Americans compared to white people. And that's something I wouldn't have ever thought of even for myself to address. So it's so important just to meet each individual where they are, talk to them about what they're thinking, what their experience is, and what their thoughts are, what they know or don't know, and educate at every level of that, and allow them to make that decision for themselves. And then it is a choice that they have. And it's also a choice that, like everybody is saying, that the facilities and the organizations have to do what they feel is best for their organization and for their patients, especially. Don't underestimate the messenger. There was another, I worked at 2 outpatient facilities, and I went to another one where that wasn't my primary site, but I had heard that there was a lot of angst and anxiety around it. And I said I'm going to have a little powwow with them as well. And I did. I kind of did the same thing that I did at my primary site. And when somebody came up to me afterwards, he said, "Dr. G, I wasn't getting that vaccine, but because you talked to me and then you got it, and because you feel like it's okay, I'm gonna go ahead and get it." So not to say because of me, but really the messenger can be quite important. And to Reverend Doctor's a point about who can help have these conversations, whether it's faith leaders, community leaders, people that people trust, family members, all of those people that they can see that they're getting it, they're okay, they endorse it. That really does help. And don't underestimate the misinformation out there. I was actually just somewhere and I was overhearing somebody talking about how the vaccine goes to the brain because somebody had a headache after they got the vaccine as one of the common side effects, and how that's going to make people have seizures. And I mean, just again, there's just so much out there that if you do have people that are hesitant, really just talk to them about why they are and see if that's something that can be discussed, and also look at those alternatives to mandating if there are available at your facility, whether the person can work in a different area, or, especially ensure that there's protection and PPE and all of that. And then access. Hopefully, where we are mandating healthcare workers to have vaccination, there's access at those facilities. But again, not underestimating that might not be the case, and where people can actually go. There are still communities out here that have about 10 to 15% vaccine rate, and it's not all about hesitancy. There's a lot still about access. And so with that, I will stop because I think my time is winding up. But I think my points are just about education and transparency and the experience, addressing where the hesitancy is, and using effective messengers to make your points, and to have those discussions with people. Thank you very much.
Dr. Gadabak, thank you so much. And I'm starting to see some really important themes emerge here as our different speakers talk. I think we saw Dr. Kaplan talk about the very real tug and pull over greater good, even within an organization, versus individual rights. The Dr. Derek DeWitt spoke to us about some of the very real pressures that are kind of, driving different decisions that as providers we need to make. Protecting our residents, the financial realities that we're facing to operate our facilities. And, I think one of the things that just struck me, there's a few things, and that you mentioned. One, that if it's in someone's mind when it comes to declination or hesitancy, it's probably a reality that we need to deal with in one way or another, and not to underestimate the wide reasons and things that drive those declinations or hesitancy. But also, I think Dr. Kaplan brought out that vaccination campaigns aren't all the same. And not only is the EUA element of the COVID-19 vaccination campaign an important consideration, but it also struck me, many of us, when we talk about this trusted messenger, a lot of us trust our primary care physicians because we have built relationships with them, and we trust their guidance. And when I think about the COVID-19 vaccination campaign, it's not always our primary care physicians that are talking directly to us, or even in this case, ordering the vaccines for us. There's a lot of other emergency actions that have been put into place to let others take care of the individual order for vaccinations. And it's kind of changed the role of primary care physicians in this particular campaign. And I think where we can find that trusted messenger, whether it be a pastor, as the Reverend Dr. DeWitt pointed out, or a primary care physician that someone trusts, it's really important to realize who breaks down our individual hesitancies and who we trust to receive information from. So thank you so much. Next, it is my privilege to introduce a colleague in many settings, including as a fellow board member with the Eastern Pennsylvania Geriatric Society. So I'd like to introduce David Hoffman of David Hoffman and Associates. David is the president of the law firm and is a national healthcare, which is a national healthcare consulting firm. And David is a practice professor of law at the Klein School of Law at Drexel University. And tonight he will address the legal framework and implications associated with mandating vaccines. David, please take it away.
Thanks, Vic. And I'm thrilled to be here with the opportunity to speak with all of you this evening. The presenters so far have been tremendous, so I'm feeling extra pressure. All of us on this call tonight, whether attorneys, physicians, nurses, social workers, advocates, all have one thing in common, and it's so rare these days that we all share something. We share our concern for patients and residents of facilities. And as Dr. Kaplan mentioned, and I'll talk a little bit about do no harm and other kinds of oaths that we all take to protect our patients, to protect the vulnerable residents of nursing homes and community living arrangements for those with developmental disabilities. We all share that common bond. And so all too often we talk about what divides us, but that's what unites us around a very difficult issue. So I want to talk about the legal guardrails and perspectives pertaining to mandatory vaccination as we move forward with our discussion. The Equal Employment Opportunity Commission, everyone knows it as the EEOC, is tasked with enforcing the Americans with Disabilities Act and the Rehabilitation Act, which addresses discrimination based on disability. Title VII of the Civil Rights Act talks about prohibits discrimination based on race, color, national origin, religion, and sex. The Age Discrimination Act, Age Discrimination Employment Act, deals with age discrimination for those age 40 or older. And the Genetic Information Non-Discrimination Act is also important here in terms of looking at this from an employment perspective and what can employers do to enhance the protection of the patients and the residents who we all care about so deeply. And then there are state and local laws that may also be implicated as we talk about mandatory vaccination. So let's get right to the first big question. Can an employer mandate the COVID-19 vaccination of its employees? And the answer is yes. The Equal Employment Opportunity Commission stated that employers may require COVID-19 vaccination of its employees. And these employers are allowed under the ADA to have a qualification standard that includes a requirement that an individual shall not pose a direct threat to the health or safety of individuals in the workplace. Think about that. Think about what we're talking about. Healthcare workers on the front line under these circumstances, unfortunately, pose a direct threat to the health or safety of individuals in the workplace, not only to patients or residents, but also to their fellow workers. Now, qualification standards are personal professional attributes, including skill, experience, education, medical, physical, safety, and other requirements. These standards predict whether an applicant can perform the essential functions of a job. And it requires an individual assessment of factors in determining this direct threat. Well, let's talk about this because we're really talking about the risks associated with COVID, the duration of risk. Well, we know we're in a pandemic. We know that unless and until we reach herd immunity, we have a very real ongoing threat. And the way we're headed now, unfortunately, is not trending as well as we would like it to be. So the duration of this risk may be longer unless we take more dramatic steps. The second assessment, the second factor, is the nature and severity of the potential harm. Well, let's talk about this. We know that there have been over 3 million deaths worldwide, that 142 million cases exist. In Pennsylvania, 1.1 million cases of COVID with close to 26,000 deaths, unfortunately. And it's not just deaths associated with this. We know there are lasting effects so far. We don't know long-term, but we've heard certainly anecdotally that people who have gotten this virus have had significant problems that are long-lasting. And next we get to the likelihood that potential harm will occur. Well, we know that not everyone reacts the same way to the virus, but it is concerning about this potential harm and what it will do to us. And then we get to the imminence. We can get it, we can spread it. We're not sure even if we're vaccinated, whether we can spread it to others. And the variants are making it even more difficult moving forward. So the time to act really is now. We are over a year into this. And so when we're evaluating this direct threat, I think all of us can conclude reasonably that we need to take more aggressive steps. Now, as Art mentioned, there are exceptions to mandatory vaccination policies. That if the vaccine would exacerbate an established disability or medical condition, if it's against sincerely held religious beliefs, which he mentioned, that these are exceptions to mandatory vaccination. And of note, even the vaccine guidance itself states that individuals who are allergic to components of the vaccine should refrain from getting it. So what does that lead an employer to do? It is required to come up with a reasonable accommodation, which is really just defined as a change to the way things are normally done at work. And so let's think about this from a reasonable accommodation perspective. What would we do if someone alleges that they have these exceptions and fall legitimately and validly within this exception to a mandate? Well, we know about mask wearing. We know that mask wearing can be effective. But if we're going to allow staff to choose to assert this exception, then a reasonable accommodation at a minimum has to be, in my mind, an N95 mask that fits appropriately to standards, that employers must provide PPE and other safety equipment to keep the workforce safe. But none of this is cloth masks for my mind. I mean, if we're really going to allow frontline healthcare workers to continue to interact with patients as a reasonable accommodation, and this is a thought process, this is not, again, legal advice to anyone, I would say that at a minimum, you'd have to take the most aggressive approach, and that non-compliance with mask wearing is something that would lead to termination immediately. When we look at OSHA, a couple weeks ago, the Pennsylvania Patient Safety Authority sponsored a program, and we had an OSHA representative speak to the group. And it made very clear that OSHA requires fit testing as part of respiratory protection programs. OSHA is going to be aggressively focused on compliance with this, because of this is not last April. This is April 2021, and these requirements have to be met. But let's talk a little bit about healthcare workers, because sometimes we just say we're going to do this and we're going to do that without having any feeling or empathy as to what healthcare workers are experiencing. You know, it was stunning to me that the CDC had said the number of about slightly over 1,500 healthcare workers had died. But then a study came out in the beginning of April that said, no, that number is not right. That in fact, more than 3,600 healthcare workers have died from COVID-19, with the majority of people who have died under the age of 60. So while the nursing home experience was the elderly, I'd like to think under age 60 is not elderly. And as a result of that, this is a significant impact on younger workers. And these were frontline workers, not solely treating those workers who were treating patients. So our frontline workers put themselves at risk. Home care workers going into patients' homes, facility staff. Everyone takes the oaths to say, do no harm, as we heard in the Florence Nightingale oath. But at the end of the day, really at the end of the day, the trust that is so important between your healthcare provider and us as patients or residents of the nursing home is critically important. And so what do we trust our healthcare workers to do? We trust them to not harm us, to not come into our homes or come into our rooms and spread a disease or a virus that could kill us. It's not that hard in figuring out what a reasonable standard is. And that brings me to the nursing home population, which we all know what long-term care facilities have experienced and the death rates in nursing homes and the residents and staff at risk. And that the fact that family members who are essential caregivers were denied access and continue to be denied access if there's an outbreak. But I pose this to you because it makes me lead to a mandatory vaccination approach. Why do we have mandatory elder abuse reporting laws? We have them in nursing homes. We have them because this is a very vulnerable population. This is a population that needs special protection. And yet when we look at this vaccination rate for staff, we're looking in Pennsylvania that 52.6% have been vaccinated as of April 1st, compared to 78.8% of residents. Now, that's a great number. I think it's great that the residents are moving forward, but that still leaves 20% of the residents being exposed and 50%, close to 50% of the staff. And so I'm concerned that these individuals, the nursing home population, continues to be at risk. And so we heard, I thought very reasonably and very appropriately, the concerns that we're worried about: fear, education being a critical component, this EUA versus biologics license approval. There's been a lawsuit filed already in Arizona where there was a corrections officer who was, as a condition of employment, was mandated to get a vaccine. He sued, and he sued saying it was, amongst other things, this is under an EUA. And the whole issue around the EUA, from my perspective, is that yes, it is an emergency use. It's not fully approved. But as Art mentioned, the numbers are staggering in terms of people who have gotten it, as opposed to a couple thousand people. But the whole statute talks about an informed consent process at the end of the day. That's what it's talking about. And so nobody's holding healthcare workers down and forcibly vaccinating them. But I'm not aware of any constitutional right for an unvaccinated nurse to work in a nursing home. And so at the end of the day, what we're talking about, I think from a legal perspective, is yes, a consenting process, and that has to give someone the right to refuse, but it doesn't tell an employer you have to continue to employ that individual. And as Art mentioned, the seminal case was the Jacobson case back in 1905 around vaccine mandates were upheld, childhood vaccines as a condition of school entry. All of that is clear in the law. as a legal precedent for vaccine mandates. So I'll finish. I know Vic stole a couple of my minutes, so I kept track. So Vic, I'll finish quickly. This is what my recommendations are to healthcare employers that I think would be appropriate. First, educate. Use all available resources, videos, experts, colleagues, leaders, and do a full court press on education across all shifts and make everyone available if necessary in person across all shifts. Facilitate. Paid time off for vaccination and recovery. If this is one of the big fears is, look, if I get sick and I can't work and I'm going to be out, I won't get paid, take that off the table. PTO for vaccination and recovery. Book vaccinations for staff across all shifts. Offer on-site vaccinations across all shifts if possible. Cover transportation costs, as the Reverend said, which is right on the money. Offer incentives. I don't consider them as bribes. If you need to incentivize people, that's fine. But after you've done all these things in a reasonable period of time, and I think time is of the essence, after you have done all these things, you then implement a mandate, is my recommendation for employers in order to protect patients and residents. So with that, I'll turn it back to Vic.
David, thanks so much. And, I'm so glad you brought up informed consent. We will talk about that in a minute. And it's such an important piece of this, our obligations. And we seem to always see this with our residents. But truly, making an informed decision about one's healthcare and with our staff, being able to provide that information, that education to help create a very informed decision-making process is certainly an obligation we have in many ways. So we'll talk about that in a minute as well. The next speaker is truly my privilege to introduce Angela Burnett. Angela is the lead PCA with Mercy Life. And, we gathered tonight to talk about, as providers, caregivers, clinicians, practitioners, the struggles we're seeing and the challenges we're facing in caring for our residents, caring for our staff, and thinking about the COVID-19 vaccination campaign, and particularly how that affects our frontline care workers and both in protecting them, but also in protecting our residents at the same time. So it wouldn't be a very good discussion if we didn't have a frontline care worker speaking tonight. And Angela has very graciously agreed to talk with us a little bit about some of the things she faced and some of the things she recognized as she went through the vaccination decision process. So Angela, I'm going to turn it over to you. And again, many thanks for being with us this evening.
First, I would like to be a part of this meeting. This is awesome. Good education from both sides, like the tug and pull. I would like to say I am a frontline worker that did receive the vaccine. I do have a lot of unanswered questions, that I was concerned about. Meanwhile, I am taking care of elderly adults. And also I have a ill husband. So I didn't want to risk, coming home around my loved ones or being around elderlies that I will contract the vaccine to. So meanwhile, while I'm trying to do my study, I said, let me get the vaccine. And I don't want it to be heavy on my heart on, why I passed the COVID-19 to someone. I had spoke to a lot of my colleagues about it. And of course, they have their reasons why they refuse, because there's not a lot of education and we still learning things as we go. I also like a great point of the PTO being used for recovery, because me having COVID back in March 2020, it was very hard to deal with. It was still new. I'm a very healthy individual, and it still was hard for me to get through. To go back to also, if we have someone in a facility, a loved one, and I would like a staff member, to be vaccinated to take care of my loved one. So it's kind of back and forth of how we really feel, how the vaccine should go. But like I said, I still have some unanswered questions and concerns. I have colleagues that's also said they would not get the vaccine, that they rather risk on getting COVID and passing that way. I have a big heart. I can't do that. I had vaccine. I had the COVID. I know how it feel, and I would not want to experience that again. Yes, I was a little ill when I did receive the vaccine, but it was only a couple hours. But just so I just like to say for the staff that are going back and forth, if we just had a little more education on it, do we have to receive a booster? How often am I going to be ill? So I just like to represent the first line workers that's taking care of our number one. Our number one is taking care of our elderly patients. So I am here to give the help that's provided, and hopefully, things can be turned around, and it will get better. So thanks for having me.
Angela, thank you so much. And I think, again, understanding that as providers and healthcare professionals, no matter what our role, from, our frontline care workers to our physicians, we don't just serve our residents, we serve our staff. And when our staff is healthy and feeling secure, we have a better chance of having continuity of care for our residents too. So thanks again for being with us tonight.
Yes, thank you for having me.
What I would like to do here is just talk about one other issue tonight. I think as the Eastern Pennsylvania Geriatric Society, it's a wonderful thing for us to open this dialogue and point out all the challenges that we face, but also we have an obligation as a society to at least talk about ways to approach things, beyond simply maybe just going to a mandatory program right away and, in a vaccination campaign like this. I'm going to pull up some slides here that I'll move through pretty quickly because I want some time for questions and answers. Nope, that's David's slides. So while I'm trying to find my slides, and just in case, again, my name is Vic Rose, and I do serve as the board president of the Eastern Pennsylvania Geriatric Society. But I also serve as director of aging services for ECRI Institute. And ECRI is a not-for-profit independent patient safety institute. And as you might imagine, given the nature of our work and risk, quality, and safety, we've been asked a lot of questions through the pandemic. And those questions we don't always have answers to. And a lot of that was around vaccination campaigns, and even understanding, how this SARS-CoV-2 virus behaves and what we can expect from COVID-19. And, frankly, because we don't have all of that evidence-based medicine yet, this is really going to be a process. And I think, this is a global process. This won't be an event. And as we learn and as we build our evidence-based medicine and can answer questions, it's so important for us as leaders, providers, practitioners, caregivers, to continually inform our processes and respond to this information we get. So one of the things, and I saw this, recently, this was in the New York Times, and I know a lot of our speakers tonight emphasize some of the pressures that are out there when it comes to vaccination acceptance rates, and what to do about it. But this is a pretty dramatic graph, and in the gray area here to the right, what that actually is past that gray line is when vaccines became available. And so really when we look at, through the course of the pandemic and we look at deaths in nursing homes, what we saw is once we did start to vaccinate residents and our staff who were accepting the vaccine, we started to see the deaths that were occurring in nursing homes no longer outpace or keep up with drive the total US COVID-19 deaths in the United States. So, right away, we started to see, and we saw some of our hopes realized, that the vaccine was having a positive effect. It was starting to create a different care theater that protected residents and staffs in a different way, who had not necessarily been protected through a lot of the pandemic. And I think that too, probably put some pressures on for us to consider, hey, we can see that the vaccination process and accepting the vaccine can actually prevent harm. And so that was another pressure that kind of added to things, as well as gave us hope. I know on Monday, the PA Department of Health posted the results of the vaccine needs assessment survey. And I think this was a really poignant thing. Originally, the CDC did a study of about 11,000 nursing homes. And early in February, the vaccination acceptance rates that we were seeing, residents were already at that point at 78%, but staff and contractors were actually at 38%. What we've seen now, at least in the Commonwealth of Pennsylvania through April 21st or 19th, 2021, is that the staff acceptance rates have increased to 52%, but this is still a pretty significant gap. And I think the thing, as I looked at these statistics, what really struck me is having worked with so many providers, so many caregivers who have struggled with so many challenges and given their full measure in so many ways through the pandemic. Even though our residents and staff were experiencing the harms, the challenges, the fears of this pandemic of COVID-19 together, even with that fact, this really demonstrated how when it comes to vaccine hesitancy and vaccination acceptance rates, groups behave differently. And that inside of our staff population, there were some legitimate and deep felt reasons that were driving our hesitancy rates. And that really led to tonight's question. What is the best practice? Is it mandating a staff vaccination program to keep everyone safe ultimately? Or are there some other approaches that, while more intensive and perhaps not quite as fast, might have better long-term benefits? And so one of the things ECRI was working on was, really using the QAPI framework to look at declination and declination data and creating PIP projects, performance improvement projects to drive up vaccination acceptance rates. So one of the first places we went, and I really love that Joint Commission framed the issue this way. The Joint Commission standards around infection control and vaccination stated a couple things, and I've highlighted them in red here. After saying that, you should, as a provider, establish an annual vaccination program for residents, licensed independent contractors, and your staff, and that those campaigns need to be treated differently. They're not going to always behave the same way. But there were some other key things as well, that providers really should set incremental vaccination goals. That at least annually, they should analyze the reasons personnel decline vaccinations and annually strive to improve vaccination rates in accordance with organizational objectives and goals. And this really sets the stage for us to use a QAPI approach to driving up the vaccine acceptance rates. So, when we talk about root causes and conducting a root cause analysis, certainly in the current campaign, there's some real challenges we faced in driving up vaccination acceptance rates. Limited access to vaccines has been an issue. The limited number of vaccination clinic dates, inconvenient times that didn't work for everyone. And really this last one as well is the one I want to focus on here, is the reasons for declination. And I think with a little bit of work inside the organization, a process can be set up to really take this QAPI approach where declinations are treated as a source of data and used to inform the education process and communication process. So, I just wanted to talk for a second about that. I'm going to go ahead and break from what we've done here just for a second. I'll ask you to use the chat function Eileen, if you're on, maybe you can monitor the chat function for me because I can't see it right. Oh, I might be able to open it. Hold on, I can.
I can.
Great. But I would ask, are there any unique reasons or specific reasons or patterns that you've heard in your work serving older adults and working with direct caregivers in our sector, in our industry, when it comes to declining the vaccine? Was there any poignant ones or any that just really stuck with you? And if there was, please add it into the chat function now.
I'm not seeing anybody responding just at this point. If you want to keep going, I'll let you know if I'm sorry. Now we are full of people. Vic, can you see this at all?
I cannot because I'm sharing.
Okay, so Angela Huffman says that the vaccine is too new, not enough African Americans involved in the trials. Heather said miscarriage of pregnant women, infertility for younger women, precursor to the mark of the beast. Dr. Donna Raziano said, God will protect me. Reverend DeWitt notes again the history. Sarah Popkins says emergency use authorization because it's not FDA approved. Also waiting to see what the long-term effects will be. Angela Huffman also said breastfeeding is a reason. Jessica McLean says, we see when working with agency-based nurses and nurses' aides, they fear becoming ill due to the vaccine since many agencies do not offer health insurance. And I imagine also they don't have paid leave. Stephen Gambisesia says, waiting for the one shot. I suppose Johnson & Johnson, and now we have a delay with that. Dr. Donna Raziano again, my family will be fine if we get COVID. Dr. Annette says, don't know the long-term effects. That's something we hear a lot. And I didn't get the flu shot. Why should I get the COVID shot? Vic, you're on mute.
Thank you. Great. Thank you so much, everyone. And I know, Annette had pointed out a specific one, Eileen, that you came across, which, had to do with, having a different vaccine or different needles or shots for different groups of people. And I think, what strikes me when, and I have a list here of some of the things ECRI's run into as we've worked with, people across the world when it comes to the vaccines, and all these you've mentioned in one way or another. But, I think the thing that struck me is I've worked to help inform and work with providers to develop education programs and informed consent programs is, while not having evidence base is important, I think too that when we start to delve down into individual reasons, whether that be in groups of people or even individual people due to life experience, science and evidence doesn't always ever overcome every reason. And I love the messages that came out tonight about taking the time to speak with people and taking the time to make sure you're the right messenger for giving a particular message and matching that up with the needs of the people who are making these decisions. It's not always just the evidence, but so many times it's making sure the message is delivered the right way. So Eileen, thanks for jumping in and helping me out here. When we talk about developing a declination form to help drive QAPI efforts or a PIP project, there's a couple things to keep in mind. A vaccine declination form should be developed for each individual campaign because not everything's the same, as we've really talked about tonight, between even the influenza campaigns that we run and our COVID-19 campaign. David touched on this, and I was so glad to hear it. We would at ECRI recommend including any policy-based rules in the declination form. For examples, employees who refuse or cannot get the vaccine, and if there's rules that they have to follow, like wearing a mask, to make sure that's in the declination form and that you've explained the reasons for that, and the person understands also consequences for not following rules. That the person's statement of refusal and the reason for the refusal we'll show an example of that here in a second. Statement emphasizing that after these discussions, the patient understands the risks of refusing, that all dates and times, of course, are documented, that you obtain important QAPI information about those reasons and use them to inform your ongoing performance improvement efforts, and that, of course, you keep and maintain those forms. Early on, as the vaccination campaign started, my team, at ECRI really wanted to talk about how do we collect declination data in a meaningful way. And, because ECRI really focuses and does a lot of work in risk management, we realized that there was a couple different types of declination forms that were developed. And, we wanted to provide some examples. So, here we have a very basic declination form that probably provides a lower quality of data. It documents the refusal, it gets signatures, but what this doesn't do is it doesn't collect information as to why a person's refusing. And so that can make it really hard to use that data to inform improvements in education and communications to your stakeholder groups that are participating in the campaign. We see a second form here. This is a little better quality data because this form, now while it's the influenza vaccination process, this particular form does include the reason. It asks the person for the reason they're declining. But again, when we talk about data analysis, leaving everything as kind of an open field that people can give different reasons makes it much harder to analyze that data and look for patterns. So while this is a step better, it's still not quite, the best that we can do. In, doing our research, we did come across this form from the LA Department of Public Health. It is publicly available, and I've asked Tina from EPGS to send this out to all of you, just in case you'd like to use it. This particular form takes things one step further. Not only does it include the things that were in the first two forms, but it categorizes the declination data, which allows then your QAPI team to start to parse it out, look for those common themes. These were some of the things that the LA County Department of Public Health highlighted. I'm allergic to a vaccine component. The vaccine is against my personal belief. I believe I can get COVID if I get the shot. I had non-confirmed COVID and I believe I am immune now. I had confirmed COVID and believe I'm immune. I do not like needles, et cetera, et cetera. But what this allows you to do then as a provider and in a PIP project is to start to understand how declinations are pooling in your organization, whether that be, any stakeholder group, a resident, a staff stakeholder group that's filling this out. And then you can adapt your messaging and your education based on this data. And we've heard this tonight, so I'm not going to spend too much time on it. You've covered it in your reasons. But once you have that data, now you can build that and continually evolve that education program that speaks to individual needs. And that's so critical in building trust and helping to walk people through their fears about getting the vaccine or their own personal vaccine hesitancy issues. There's a tailored communication program, and this made me smile throughout from all of our speakers because so many of these messages were crafted or were discussed tonight, especially this first one. Identify the best and most trusted messenger who will get the message across, and I'd add in the most meaningful way. We talk a lot in the second bullet about talking with our residents, including them in their conversations, not talking around them. And so I think that's true too when we talk about a declination or a vaccination campaign and the education program that goes with it. And finally, informed decision-making. This is really what this particular process helps to do as well when we educate, is it does build that informed decision-making process so that people are making very informed decisions, whether that's to accept the vaccine or decline it, and really to help the people walk through their own process so that they start to realize what their hesitancy might be. And I thought Angela brought up a good point. As the campaign has progressed, we've seen some of the fears that center around, is it safe? What's the evidence? Can this hurt me? Kind of subside because we're seeing people get the vaccine and we're not hearing about certain types of problems. And so I think that's what we need to realize. This is a process, not an event. With that, I'm going to kind of wrap up. I know we're at our time, and I am going to at least open it for anyone that's with us yet to pose any questions to the panel. Again, please feel free to turn off your mic and pose your questions, or you can type them in your chat function. I know we had an awesome panel, but perhaps there's something that went unaddressed tonight.
While we're waiting for people to respond, I just wanted to mention that the province of Ontario, Canada, decided that they would pass a law that would prevent nursing home staff from working at more than one facility. And I just wanted to throw that out to not only the speakers, but the participants. How would that work if we did a similar kind of thing? Thanks.
Yeah, this is Derek DeWitt. I do want to say something in reference to what Dr. Annette said. It's really important not to underestimate the reasons why, or to discount the reasons why people have hesitancy. And I will say we had hesitancy, and I think I mentioned our first vaccination clinic in December the 23rd. We only had 11 out of 42 employees at one facility. And it took a lot of sitting down one-to-one conversation to overcome the hesitancy. And a lot of that was related to just a lot of misinformation. Some people's hesitancy is rooted and grounded in a very real reality of history, especially in the African-American community. But we're able to talk through that. And somebody mentioned not talking at them, but listening to their reasons and helping them to overcome their fears. But I will say that the one-on-one conversation has been the best tool for me to overcome the hesitancy as it relates to the vaccine.
Question for Professor Hoffman.
Good.
Professor Hoffman's an expert in compliance, and I'm just the questions about validation. So vaccine recipients are walking out with this 3x4-inch card. So this is the document that validates that. It wouldn't be too hard to suspect that a blank one, there's stacks of these around. Somebody could take a black one. Seems like an HR headache. So there's the document validation. How far are they going to track? Are they going to go into other data systems, or are they going to take a moral certitude that when I come and I have the date, even if I may have copied the lot number and the dates, it wouldn't be too difficult to do. I want to be optimistic, but the data, Professor, I'm looking at is how's that going to work?
It's a great question. And I think as soon as it becomes to have an advantage, to have this document, as you point out, this is your get into a sporting event card or get into a movie theater or some entertainment. I think there is a risk. There is a risk that there'll be fraudulent kinds of documentation provided that will, and I've heard some of that's already out there in terms of a concern. So whether you create a national database, I think you're going to have a big pushback on the privacy arguments and Big Brother grabbing all your personal data, health data. It's going to be a very interesting dynamic, and it's going to evolve over time. And how to validate this, I think, is going to be a challenge. As soon as there's some incentive beyond just your own goodwill or proof that you had it done, I think it's going to be a challenge. So it's a great point, and we should start thinking about it now.
Stephen, this is Vic, and that's a great question. ECRI gets posed this question as well, and from an enterprise risk management perspective, how to deal with it. So there's a couple points too. When we calculate vaccination acceptance rates, one of the things we actually need to do is account for staff that have gotten the vaccine elsewhere. And what we would recommend as another measure is, that's a reason for declining the vaccine in your organization. So I would treat each declination because someone has gotten it somewhere else, get that form signed, go through the ramifications of providing misinformation, and let them know, in the case of saying, yeah, I got it already, if it's discovered that they forged a document, just like anything else in healthcare that can really carry serious ramifications. In this case, residents and other staff getting sick. Then you have something to go back. And I think over time, if we start to see people are forging these documents, and there's serious ramifications for doing so, it will create normative expectations out there that it's not permissible. It's an excellent, excellent question.
There's also a question from Angela Huffman in the chat box. Does anyone have a policy in place for unvaccinated staff? I think, Vic, you may have that. What are the approaches that you're using? Full PPE, N95s in all zones, those kinds of issues?
It's an excellent question. And, really, when we talk about what the appropriate PPE assignment is for someone who's declined, it's the highest state we've been operating in at the peak of the pandemic. Ultimately, I think, I think there's some concern.
Figure out who's doing that.
Okay. I think there's some concern right now that, we say, if you don't get vaccinated, then these are the things you have to do, including the PPE you have to wear. But even as of today, there's still pretty high PPE expectations. But I think as we start to move beyond the peak guidelines that have been put into place, that requirement of PPE will carry a little more weight again, especially as we start to lessen those guidelines. But I think that's really the only thing we can do to protect anyone else who couldn't get vaccinated, anyone else, any resident who for whatever reason has refused to get vaccinated, is require that PPE piece, and document it. And again, anytime you make a policy-based rule like that, if you're not vaccinated, then you need to do this and this and this, put that in the declination form, make sure you explain that and why, most importantly, why, the harm that can come out of not being vaccinated. I love what Angela said as well. She talked about the harm to family members and others in her circle, in her bubble, if she were to contract COVID-19 and passing that on to them. And they're all important conversations in that one-to-one discussion when someone says, no, I just don't think I'm going to get the vaccine. So it's a great question. I will see, Eileen, if I can find a nice template, policy template, and we can distribute that as well to attendees tonight.
Okay, great.
Mm-hmm.
Are there any other questions? We're over by about 5 minutes, but in any final comments, do any of the participants have anything else that they'd want to add?
Great. So just from my perspective, everyone, thank you so much for attending tonight. We know your time's valuable, especially after the last 14 months. If you're serving older adults in any way, we hope this was, a valuable and meaningful session for you. If you have questions, please reach out. Again, I'm blessed to serve with such an incredible bunch of board members and colleagues they work with. And I feel certain if you have a question and send it to us, this group will get together and come up with an answer, and it'll be a very unique one indeed. So blessings. Thanks for all of your service, and thanks for supporting the EPGS. And we look forward to seeing you again at our next event. And if you're participating in research night and have questions, as I said, please reach out to us. Take care, my friends. Be safe and well. And thanks for all you're doing to take care of our older adults.